Today we are doing an abdominal exploratory on a dog that has probably an intestinal foreign body. So it's a 4-year-old clinical foreign bodies, and so we're going in to have a look and see what we can find. So if you haven't already done so, please like and subscribe to our channel, turn on notifications so you'll get a ding on your phone the next time we live stream. Camille, can you hit that other frame? Thank you.
We'll just wait and see, Camille, because we've got a couple of foreign bodies today. Yep.
All right, so starting abdominal exploratory, really important that we get adequate exposure. So we're going all the way from the xiphoid all the way down to the penis. And I'll just get you to retract on the other side. Now, because this dog has had an exploratory previously, can I get coag turned up to about 8? Yes. Because it's had an exploratory previously, the possibility of adhesions to the underside of the incision. So when we do enter the body wall, I have to be aware of that. And you can see the sutures from the previous exploratory that it had for the prior intestinal foreign body. The dog was really unstable when it came in earlier today, but the critical care guys have done a really good job of stabilizing it. So it's better. What's our blood pressure now? 105/51, so that's great. We've got it on noradrenaline, as well as fluids and dextrose because it's hypoglycemic. I'm just palpating inside to make sure that there is nothing adhered to the inside of the incision. It's interesting how small the previous surgical incision was. It really needs to be bigger than that in order to see what's going on inside the abdomen. The other thing is that the falciform fat wasn't removed, and although I guess you couldn't really see the falciform fat from the size of the incision that was done previously. So if you are doing an X-lap, you really need to go in and remove that falciform fat. So far the abdomen doesn't look too bad. Doesn't look like it has raging peritonitis, which is a good thing.
Do you know what the foreign body is?
We don't even know if it has a foreign body. So we don't know what the foreign body is, or if it is, or what's going on in here. So it could just be adhesions from the previous surgery. Wasn't done here. I've got a new streaming setup that this is the first surgery that we've used it on. So hopefully it works well. At some point I'll do a little live stream where I'll show you how I live stream. So the next thing we need to do is put in Balfour retractors, making sure that we're not pinching any intestines against the body wall. And we're just going to extend a little bit further up, all the way to the xiphoid. As long as you stay ventral to the xiphoid, you won't go through the diaphragm. Yeah. That's the umbilical, or the falciform fat's bleeding a little bit, so I'm just going to reassure that. It's not dangerous bleeding, it's annoying bleeding, and it just keeps you from being able to tell if there are other sources of bleeding in there. Alright, so next thing we're going to look at the liver. That all looks pretty good. A little nutmeggy. And the stomach. Some gas in there. Coming around to the duodenum. I'm going to use the mesoduodenum as a retractor so you can see the pancreas there. Got a little bit of an adhesion from the pancreas to the caudate lobe of the liver. Looking at the kidney, looks like there's some renal cysts there. A little bit of free fluid, but not much. Coming down the caudal duodenal flexure. Just get all these guts out of my way. So duodenal colic ligament that's going to restrict our ability to totally exteriorize the caudal duodenal flexure. So now I'm into jejunum. It doesn't look hugely dilated. I think I've twisted things around a little bit, unless that's the problem. So there's a prominent mesenteric lymph node. I am having trouble tracing this around. Okay, so that's the continuation of jejunum there. Adhesion there that's probably from a previous enterotomy, but it doesn't look like it's obstructed. Coming around here. It's possible this is going to be a negative exploratory. The guts are looking a bit flaccid, like a foreign body's been through here. Now we're down to the ileum. Put the spleen out of the way, have a look at the left adrenal gland here. And then the colon is there. Can you hold on to that, please? So back to cecum. Coming back around the other side. Just going to run it again from this direction. So that's going back jejunum toward duodenum, I would imagine. And that's ileum there. Down and make sure. And the owners refused a CT scan. We offered to do a CT scan beforehand. And I said, no, it's definitely a foreign body, because it's had them before. So that's just a little adhesion there. So the only place that I can think of that there's a problem, and they probably are mentalized the previous intestinal surgery. So that's why all this omentum is stuck on here. But that doesn't look obstructed to me. feels a little funny right here, though. Can we get Liam in here, please? I'm going to break down this adhesion to the omentum. This is why we always try to do CT scans before we go to surgery. Hey Liam, it's a negative exploratory.
Okay.
Yeah. So,
Well, that's good news.
yeah, so there's an area here, there's like some old adhesions from previous surgery, and there's an area in the mesentery which is kind of thickened here, which is probably a previous surgery site. Do you know how long ago the previous surgery was?
It would have occurred around 6-8 weeks ago.
6-8 weeks ago, okay. So it's not unexpected that there are going to be some residual inflammatory changes, but there's no evidence of obstruction there at all. And with acute clinical signs, I don't think it makes sense to do biopsies or anything. So, you happy with that?
Wonderful.
All right, so let's get some warm lavage.
Thank you very much for that.
Pleasure. So it's not common we have negative exploratories, but
Yeah.
yeah.
I've prepped
Anyway.
super lovely, so.
Yeah.
Easy.
All right.
I'll give her a quick call.
All right.
Are you happy for me to call her? Or
Yeah, great.
Yep.
Thanks, Liam.
Chronic change in that liver is significant visually, Charles.
I mean, it wouldn't hurt to get a biopsy, though. I mean, it looks pretty normal.
It's quite homogeneous, right?
Yeah, no, it's fine. All right, so we'll just wait for some warm saline. We'll flush and suction, and then we'll close it up. Just have a look down south here at the bladder and prostate and stuff. While we're in here, I'm just palpating the prostate. I can't feel any mass or anything associated with it. So we'll just lift this up. Is that warm already? Let's go ahead and pour that in. Don't have to do a huge lavage because we didn't enter a lumen and there's no peritonitis. Can you get some O nylon, please? Has the dog been vomiting that you know of? Hey?
Yeah, I think he's
Just ask Liam if he wants a jejunostomy tube in. So if it's been vomiting, protracted vomiting, we can't really put in an esophagostomy tube or a gastrostomy tube. You have to bypass everything and just put in a jejunostomy tube. The question is, I guess, can we manage the vomiting medically to allow us to put in an esophagostomy tube? And so that's what I'm going to ask Liam, our critical care specialist, to see what his perception is as to whether the vomiting is going to be able to be managed medically. So these are things that you should be thinking about whenever you're doing an abdominal exploratory, is how you're going to feed the patient afterward, and consider how much the gastrointestinal tract is working and how much isn't working, and you want to use as much of it as possible that's working, but if there's a part that's not working, you want to bypass that with your feeding. Can you guys comment, those of you that are watching, what the quality of the video looks like and stuff, whether there are any drops or anything like that? Because this is my new streaming system.
Gastronomy?
Gastronomy? Yeah, yeah. If he's been vomiting, you're still happy to put that in?
Yeah, so I think it's only been a couple bouts of vomiting. I'm happy
Okay.
with gastronomy.
Okay. Do you want to pick a tube?
Yeah.
Just that mushroom tip or whatever you want, and I'll put it in.
Cool, easy.
Thank you.
Where do we think?
Hey? So you guys will get to see me put in a gastrostomy tube as well. I'm going to zoom the video out a bit. So again, I assume that you guys can hear me and that you can see everything okay, but if you guys that are watching, can you comment as to whether you can see? So I see that there's been a little lag in the video stream intermittently. So this is just connected via Wi-Fi, this streaming system, and so I'll have to figure out how I'm going to improve that going forward. Quality seems to be good according to some people, so I'm just waiting for our stomach tube.
This one okay?
Yeah, that's great. And then I'll take some 3O PDS, please. All right, so the first thing that I'm going to do is I'm going to pass the feeding tube through the skin and into the abdomen. So we'll just get a blade and we'll make a cut down. Go ahead and cut down over the tip of that right angle. Just keep cutting down. Okay, and then we'll grab the tip of our mushroom catheter. Can you guys see that?
Do you always do this left-sided so that it's in
The fundus, yeah. Can you cut down over that again, please? It's a very thick abdominal wall here. Stretch that out a little bit. Okay, and then what we'll do, take this out, grab some towel clamps, grab onto the abdominal wall, like this, and then I'm going to get an 11 blade. Thank you. And I do 2 different purse strings when I put these in. So I'm going to make a stab incision all the way into the stomach. Can you hold on to the tube, please? And really stretch it out. Can we get some more towel clamps, please? thank you. Alright, so we'll hold on to the stomach here. You can probably release the two that are on the body wall. Okay, hold on to that. Just trying to jam this down into the gastrotomy that I did, like that. Okay, so that's now in the stomach. And now I'm going to do a purse string around where we put the tube in. If you're interested in tube feeding in dogs, we've got a really good VetDojo module on tube feeding. It has everything on how to put every different type of feeding tube in, what to feed them, how to avoid complications. So I'm just putting a purse string all the way around. That's at www.vetdojo.com. We've gone all the way around that tube. I'm tying that fairly tightly. The idea being that that's going to keep the tube from being pulled out prematurely. And then the next thing that we're going to do, go ahead and can I get some 2O PDS please? Release the stomach. We'll pull this up and then we're going to open this up here. Grab onto that please. And I'm going to put a kind of a running purse string that goes between the stomach and the body wall. So I'm going to take a bite. It's usually best to take the bite in the part that you can see, like that's hardest for you to see. And then we're just going to go all the way around. Take one bite in the body wall, one bite in the stomach serosa, one bite in the body wall. The idea with this is that if it was to pull out prematurely, we'd have a seal between the stomach and the body wall so that it wouldn't leak and cause peritonitis. So I hope that you guys can see what I've done there, and watch when I pull this tight. It's just going to make a really nice seal between the stomach and the body wall.
What's the process for removing these chops?
Just a short, sharp pull. Alright, so go ahead and release that. So that's nice and solidly in there. And I might have you elevate that. Yeah, and I'll take this over here and we'll start running our 3O nylon. And this is a really big dog. And so I'm using the double arm 3O nylon. O nylon. Because it is very, very strong and secure. It's used in human abdominal wall closures. And the benefit is that it has a loop on it, and so there's no knot at one end. So I've got the loop here, and I just pass my suture through. because the knot is going to be the weakest part of the suture line. And then we're just going to run a simple continuous suture pattern. And I have no problem using a simple continuous suture pattern. If your knots are, if you're confident in your knots and you've got good bites in the abdominal wall.
Camille, Ray's just asking for the Balfour.
We've got another big dog X lap coming up this afternoon, and so I have to hand off the Balfour, for the big Balfour to research. We've got about 5 different Balfours here, and I am not doing that surgery to my knowledge, and so I won't be live streaming it. So you didn't get to see a foreign body, but you got to see a gastrostomy tube. And I challenge you guys to really think about how you're going to feed your patients after surgery. And so you should always, whenever you're doing an X lap, particularly in a patient that's been anorexic, is think about how you're going to feed it after surgery. And it's better to put a tube in and not need it than to not put a tube in and then wish you had the next day. And especially with esophagostomy tubes, you can just pull them out the next day if they don't need it. If they wake up and they're eating, just pull the tube out. Can't do it with a gastrostomy tube. You want to leave these in for about 10 days.
That's for that body wall stomach to adhere, to form that seal up.
Yeah, so that's to allow the body wall, the stomach to form an adhesion to the body wall to seal up that stoma. If you pull it out prematurely, you can get leakage. It doesn't happen a lot, but it can happen. Because we put these in endoscopically as well, peg tube, percutaneous endoscopically placed gastrostomy tube. And leakage is not a big deal with those, and those aren't, those don't have a adhesion, you're not suturing that at all. Get some oak PDS, please. And some 2O nylon, please. With this big suture, I do at least 5 throws, preferably about 6 or 7. Hole for the feeding tube coming out through the skin is a little bigger than I would like, so I'm going to do a proper purse string on that as well before we do our finger snare. Now I can officially say, by the way, that Ewan's going to be our resident next year. I stuck my foot in my mouth a few weeks ago and was admonished by Ewan.
I didn't know how to respond. Wasn't sure if it was a test.
He did come up to me afterward and said, I don't think anybody knows yet. I don't think you're meant to tell anybody. Discretion is not my best attribute.
I would have never thought that choice.
Really? Are you being sarcastic?
Maybe a little.
I had a vet nurse who used to say that if they hadn't invented sarcasm, she would be a mute. That was pretty much spot on with her. I'm going to start putting a really nice purse string around that skin, like you should be doing about 10 bites around that urine. And this patient is doing well hemodynamically, but it's not the most stable patient in the world, and that's why I'm staying and helping with the closure.
Closure here and then a purse string around it?
Yeah. So Ewan and I can double team and get this guy off the table more quickly. Our lives as surgeons here at Southpaws have been made so much better by having the critical care team here. They're so good at handling, number one, they're so good at handling these tough cases pre and post-operatively, but number two, they're attracting these fun cases, interesting cases as well. So what could be better? As a surgeon, you get to cut interesting cases and then you don't have to manage them post-operatively. Really, just an ideal world. Can I please get some more 2O? It's just, incidentally, this is just a G tube, not a G tube through a, not a J tube through a G tube. Sorry, that's 2O PDS. Did I say nylon? Yeah, we get to keep the best part of these cases, which is the surgery, and hand off the hardest part, which is the post-op perioperative care, and they're getting better care than they were before. So it's a win-win situation. And honestly, with some of these cases, by treating them aggressively and appropriately early on, we're avoiding some of the complications that you would get 2 or 3 days down the road, and so the cost to the client really is not that much more often. They're getting a better outcome. And they're also available to help us with the tough anesthetics as well, managing hypotension. Yeah, great. I'm just doing an intradermal suture pattern here. Do you need something from me, Ian?
I was going to run your suture for you, so I stay out of your way doing this, so I'll finish that off when you're done.
saying that we knew we were going to keep Ewan from when he started nursing with us 4 years ago, but we had to make him sweat for a little while. What's 3 or 4 years, Ewan?
Nice. It's been an adventure. Maybe I was making you sweat, Charles.
About whether you were staying or not?
Yeah, maybe I just wanted to stay a nurse or a rotating intern.
Yeah. Look, if you want to go back to being a rotating intern, I'm sure we can arrange it.
There'd be plenty of people willing to take my spot.
Turn off suction for us, please. It's great having somebody coming in as a resident that's been with us for a couple of years, because they already know the way that we like to do things, and so they're so far ahead of the game. And they are very accelerated when it comes to being able to do more major procedures.
Your relatability is good too, like knowing what the rotating interns are doing and exactly what their role is.
Yeah.
Being able to help them. Same with the nurses.
Yeah. It's like one job interview after another. Like when we take students, final year students, it's a job interview for internship, and when we have interns, it's a year-long job interview for senior intern, and when we have senior interns, it's a year-long job interview for residency.
You want Chinese finger trap in this?
Yes. Alrighty, so hopefully we'll get this guy off the table and awake soon, so he's not under anesthetic. Alright, well, just come over and make sure there aren't any questions that I missed. Piyush is saying hello. Hello from South Korea, Frankfurt. That's interesting about the black line on the top and the bottom. I'll have to view the YouTube video when we're finished. Don't know, there was no foreign body, and we don't have, radiographs weren't really very telling about what was going on. So anyway, well, that's it for us. Thank you very much for watching. Please make sure you like and subscribe to our channel and turn on notifications so you'll get a ding on your phone the next time we live stream. I don't think I'm streaming anything else today, but hopefully tomorrow. I think I've got a pretty busy day. So thanks